Hello everyone, this is Li. Today we are going to talk about breast pathology about fibroepithelial lesion. Here's our outline. We'll talk about fibroadenoma, phyllodes tumor, hamartoma, and a few cases. First, fibroadenoma. Fibroadenoma is a benign bifasic tumor composed of both granular epithelial and stromal component proliferation of the terminal duct lobular unit, and then there are 4 variants, and then we will talk about some details about this variant. So basically, it is the most common benign tumor of the female breast, but in the examination, if they ask you what is the most common benign pathology changes or lesion, that is fibrocystic changes. And fibroadenoma is the most common breast tumor also in adolescent and young female, and the median age is 25 years old. Myxoid fibroadenoma is associated with carni complex. What is carni complex? That is the BRCA1A gene inactivated mutation, and then including all of this phenotype. And usually fibroadenoma totally benign do not increase breast carcinoma risk, but when you have complex fibroadenoma, it will relatively increase the risk of 3.1 than the general population. Here just show juvenile fibroadenoma. Their median age is 26 years old, and the conventional fibroadenoma should be 34.5 years old, so they are different. So the clinical feature just a painless, firm, mobile, slow-growing mass, usually solitary, and but can be multifocal or even bilateral. Usually very small, less than 3 centimeters, but it is hormone sensitive and may grow rapidly in pregnant. And radiology finding, you always need to see the radiology report about smooth margin. Sometimes it may be associated with calcification, especially in the postmenopausal patient. So in this radiology image, we can see this well-demarcated solid mass in the periphery, but this area, this lesion, the radiology report usually will use speculate. That means this infiltrated growth. So this is a carcinoma. This is fibroadenoma. The treatment, usually we do not need to treat unless the patient want to, or it is symptomatic, or whatever other reason the patient want to get it out. Then the growth finding, usually just a firm, well circumscribed oval mass. The cutting surface just like fibroid. We can also see some slick light space. You can find some mucoid or fibrotic appearance, some calcifications. So this is the growth image. We can see this firm, well-demarcated oval mass with bone cellulite surface. That means different kind of nodule. And then this also shows fibrotic and mucoid appearance. This also shows multi-nodulated, but also well-demarcated, like fibrotic cutting surface. There's another one. We can see this multilobulated but well-demarcated mass. So the microscopic feature, first we need to see well-demarcated, encapsulated. As I mentioned, biphasic tumor, so you need to see both component proliferation. For the granular components, there are 2 growth patterns. One is canalicular, that's the gland are compressed, and this is the most common one we can see. The other one is pericanalicular. That means the glands remain open. So the stroma, we can see this spindle cell proliferation, and we can see myxoid changes or even hyalinization. But you need to pay attention. Fibroadenoma can be evolved in other breast neoplasm, including invasive ductal carcinoma, lobular, and also other malignancy. There are 4 types of variant. The first one is myxoid fibroadenoma. So we just see this myxoid stroma changes. And complex fibroadenoma, we need to see several benign pathology changes, including cysts more than 3 millimeter. We can also see sclerosing adenosis, epithelial microcalcification, even papillary apocrine metaplasia. And cellular fibroadenoma, we can just see more cell in the stroma. And also we have juvenile fibroadenoma. We can see gynecomastoid-like micropapillary projection. So you can see some image to just show what you may consider juvenile fibroadenoma. Usually we don't do any IHC staining, but if you do, you may see the stroma cell strong with for CD34, ERPR, even beta-catenin nuclear staining, and the epithelial cell just like a normal TDLU. We can use low molecular weight cytokeratin and also ER positive. The KR67 proliferation index usually low compared to phyllodes tumor. Molecular finding, that is the MED12 exon 2 mutation. And the myxoid variant usually lack of this mutation. Another rare mutation maybe also you can find in fibroadenoma. So let's see this fibroadenoma image show intracanalicula growth. Intra means the stroma just grows in the TDLU, so it will compress the epithelial gland. So we have epithelial proliferation and also the stroma proliferation. So this is a biphasic tumor. Another one, this one low power show well demarcated border, and then we can see this in the canalicula growth pattern. So the stroma just proliferation and then also complex this epithelial component. So this slit-like area. And then this is a pericanacular growth pattern. That means the stroma overgrow just between the TDLU, so they didn't compress this epithelial component. So you can see this open lumen, but we can see this biphasic epithelial proliferation and also the stroma proliferation. This is another one, also open lumen. This is a pericanacular growth pattern of the fibroadenoma. And this images would like to show you inside the fibroadenoma. Other than these 2 components, you may also see this calcification. This is a core needle biopsy. We can see well demarcated mass, and then we see epithelial component proliferation and also this stroma also proliferation. So this is a fibroadenoma from a core biopsy. One variant is juvenile fibroadenoma. I think when you want to diagnose this, you need to have a really good clinical history. So usually size is larger and can show rapid growth, and then in a relatively younger age. And then in the histology finding, we can see kind of increased stroma cellularity. And then for the epithelial component, we can see this gynecomastoid-like micropapillary projection. And then usually you will see this pericanaliculi growth pattern. That means the epithelial component of proliferation, but they have this open lumen. And then the stroma will have more cell than the conventional fibroadenoma. And then in this lumen, we can see a little bit this micropapillary projection, gynecomastoid-like changes. This high power, we can see the stroma really hypercellular, and then we can see this benign epithelial cell proliferation forming this micropapillary structure. So combine the clinical history, we can consider juvenile fibroadenoma. Another variant is cellular fibroadenoma. we can just see the stroma had more cell. This is a example of cellular fibroadenoma. We can see this epithelial component proliferation and then more spindle cell in the stroma. High power, you can see tons of this spindle cell, but I don't know what is the definition for this kind of arbitrary. So this is cellular fibroadenoma. Another one is complex fibroadenoma. That means you've had a fibroadenoma, but you also have some benign changes, including cysts, more than 3 millimeter, sclerosing adenosis, microcalcification, and papillary apocrine metaplasia. So this is complex fibroadenoma. You can see this one is really classic for the fibroadenoma, but here you can see this dilated cyst and maybe also some sclerosis adenosis. So you can diagnose this one as complex fibroadenoma. So usually differential diagnosis of other fibroepithelial lesions, including phyllodes, hamartoma, tubular adenoma, and fibroadenomatoid changes. We will talk about phyllodes hamartoma later. So for the tubular adenoma, this is not a biphasic tumor. When we try to call tubular adenoma, you can just see the epithelial component proliferation, but the stroma just like a normal breast stroma, and then we will diagnose this as tubular adenoma. And then for the fibroadenomatoid changes, that means you have these fibroadenoma looking, both of the epithelial component and the stroma proliferation, but you do not see a mass. So that is called changes. This is a TA, tubular adenoma. Why I call this? Because I just only can see this epithelial component proliferation, but the stroma kind of a normal breast stroma, and it forming a mass. So this is tubular adenoma. So another topic today is the phyllodes tumor. Phyllodes tumor generally also circumscribed when we call this benign phyllodes, but of course we also have borderline, even malignant phyllodes, and then they will show infiltrated growth. But the most important feature, that is the leaf-like stroma proliferation and stroma hypercellularity. So in phyllodes tumor, the tumor part is the stroma, and then the epithelial component is totally benign. Just 1% of the primary breast tumor and 2.5% of the fibroepithelial lesion. The benign phyllodes are the most common phyllodes tumor, followed by borderline and malignant. Average age is older than the fibroadenoma. And then benign phyllodes occurs at a younger age. Some cases may be associated with the Flaumeni syndrome related to the p53 mutation. Clinical feature just similar to the fibroadenoma, just the size may be larger. And the diagnosis, usually the radiology could not tell the difference between phyllodes and fibroadenoma, so the patient usually end up with a core biopsy. But other than that, even for the core biopsy, sometimes it's really difficult to tell whether this is cellular fibroadenoma or phyllodes tumor. The growth finding usually similar to the fibroadenoma, but you may see some leaf-like pattern. So this is phyllodes. We can see this leaf-like pattern, but still really well demarcated. So this is still a benign phyllodes. Microscopic feature, just like what we see the stroma in the fibroadenoma, but the epithelial component, the glandular component, does not proliferate. And one characteristic feature is low power. You will see this leaf-like structure. That's the key. And then high power, you need to see whether you have some epithelial condensation. What does that mean? That means the stroma close to the epithelial component, you will see more cells in that area and less cells when the stroma far away from the epithelial component. As I mentioned, we have benign phyllodes, borderline, and malignant. And here is the criteria we can use, but still kind of arbitrary. Like for the tumor border, if we see infiltrated, we know that is malignant. But if focally infiltrated, we will put in the borderline. So sometimes you just could not tell. But the mitosis is a really good standard. If less than 5 mitosis in 10 high power view, consider that's benign. If more than 10, that's malignant. And also stroma overgrowth is a really good phenotype. What does that mean? Stroma overgrowth, that means when you use 4x objective, you can just see the stroma area, and none area you can find the epithelial component. That's stroma overgrowth. So also maybe a hint for the malignancy. Of course, you can see malignant heterologous element, including chondrosarcoma, osteosarcoma, what other type sarcoma element. You should be suspicious for malignancy. But there is a pitfall, is that if you see some well-differentiated liposarcoma that may not be malignant, you could not base on that criteria to call it malignant. But if you see de-differentiated liposarcoma component, so really high-grade feature, you can still base on that one feature, call that malignant phyllodes. So we already talked about it, and then how to tell the difference between benign and malignant. So stroma overgrowth, you can tell mitosis, tumor border, and then the sarcomatoid element. So this is a phyllodes. We can see the stroma, we have a lot of cells compared to the conventional fibroadenoma stroma. And then we have this subepithelial condensation. That means close to the epithelial area, we can see here's bluer, more blue than this area, because we have more cells just next to this epithelial. When you see this feature, you can suspicious for phyllodes. But of course, sometimes if you see this hypercellular stroma, you just could not tell whether it is a stroma from a cellular adenofibrilloma or a true phyllodes. This loci is really good to show this leaf-like structure. So for benign phyllodes, subepithelial condensation, you can see more cells just surrounding the epithelial. And then there is the mitosis. I wanted to show you. If you want to see my mitotic figure, just search around this area close to the epithelial component. So this is a low power for a phyllodes, this leaf-like structure. But if you think you can make a diagnosis by core biopsy, you can imagine if the needle come something like this, you could not see any leaf-like structure, and then you could really misdiagnose. Another growth finding for this phyllodes, still well demarcated fibrotic stroma cutting surface. But here we can see a little bit like infiltrated growth. But low power, we can still see this leaf-like structure. So this is a phyllodes but suspicious for borderline. And then if you see the stroma like this, really hypercellular, tons of cell, and then cell also show a little bit atypia, then here growth pattern almost forming this herringbone pattern like sarcoma. So we can call this borderline phyllodes tumor. Here I also would like to show you, you can see this infiltrated growth, also another feature for borderline phyllodes. And then this one relatively well demarcated from the growth image, you just could not tell whether it is infiltrated. But the microscopic feature is clearly malignant because we can see conventional benign phyllodes tumor on the right side, and then we can see these sarcoma changes, malignant heterologous component, really high grade sarcoma atypical cell. We can see close to the epithelial component in this malignant phyllodes, we can see this atypical cell, and then also tons of mitosis. The cell also show atypical. We can see some component always almost mimic de-differentiated liposarcoma, and then really atypical. We have really ugly cell polymorphism with atypical cell. Here you can see mitosis, and then cell with this prominent nucleoli. Nothing you can see this kind of nucleus in the benign entity. Here we can see mitosis, kind of atypical mitosis. Also polymorphic cell, mitosis, another mitosis, atypical mitosis. So when you see this stroma, that is malignant phyllodes. Here just would like to show you they can have other mesenchymal component, like this osteosarcoma looking, and then we can see this rhabdoid differentiation, and we can also see this skeletal muscle differentiation. We can see this striatus of the stroma cell. They can also differentiate it into this chondrosarcoma-like stroma of a malignant phyllodes. So here's a table to show you how to differentiate between benign phyllodes and cellular fibroadenoma. But I think the key feature is leaf-like structure and subepithelial condensation. And usually in a excisional sample, you can tell the difference. And then there's another table to summarize, compare fibroadenoma, benign, borderline, malignant phyllodes. So the IG staining for the epithelial cell, just like the normal porous epithelial granular component, and then the stroma usually shows positive CD34. And I don't think other marker is really helpful. And in the benign phyllodes, usually you find a similar molecular finding of this MED12 and RARA mutation. But in the malignant case, you may find other driver mutation of just like other malignancy, like the neurofibromatosis 1, RB1, TP53, even third promoter mutation, and also chromosome changes. Benign phyllodes is totally benign, but still have some local recurrent rates within 2 to 3 years of diagnosis. And the margins data is the best predictor of recurrence. And even malignant phyllodes, the auxiliary lymph node metastases are really rare. And then the treatment just local excision with clear margin. And then for benign phyllodes, a narrow margin usually is adequate. And the axillary dissection are not indicated. Radiology and radiotherapy and chemotherapy usually unclear whether it is useful in phyllodes. For the differential, we already talked about it. Then when you thinking about malignant phyllodes tumor, you may also want to differentiate, put the differential diagnosis between the metastatic carcinoma and even sarcoma. Between phyllodes and metastatic carcinoma, usually in malignant phyllodes, you may find some benign phyllodes component like leaf-like structure. Then if you want to tell for sure this is the metastatic, not malignant phyllodes, you may need to use different kind of cytokeratin marker, including high or low molecular weight pan-cytokeratin AE13 Chem 5.2. Just use all the CK marker in your lab, and if you can find strong and diffuse positive and some component that is the hint for metastatic carcinoma. If you could not find it, you just could not tell. So in a core needle biopsy, no matter who you are, sometimes you just could not tell the surgeon for sure whether this core biopsy show cellular fibroadenoma or benign phyllodes. So what you need to tell, usually if not sure, just tell them you are not sure. So just tell them this is fibroepithelial lesion, and then you can also favor phyllodes or favor fibroadenoma, but still put this differential diagnosis there and let the surgeon know you are not sure. And then usually they can use their clinical judgment to whether excite the lesion or not. Because you can imagine if you call this is fibroadenoma, line cellular fibroadenoma, and then the surgeon usually will leave the patient alone, and then it turns out to be benign phyllodes, it will grow bigger, and then may cause you some trouble. So the next entity is a easy entity, that's a hamartoma. So for the hamartoma, also well circumscribed, often encapsulated mass, and usually the radiology can tell us the diagnosis. But if they could not tell us, and then we may have a biopsy. So in a biopsy, you usually see a let's talk about the clinical feature first. So if you have multiple hamartoma, it can be seen in Cowden syndrome. That's the P10 hamartoma tumor syndrome, about germline mutation of P10 tumor suppressor. You may have multiple hamartoma of the skin, GI tract, and other organ, and also increased risk of breast, thyroid, and endometrium carcinoma. So because the hamartoma is totally benign, so the prognosis is it's really rare to recur and no increase in malignancy. So the treatment also depends on the patient preference. Usually you can just leave it there. So the microscopic feature, a lot of words here, but I just would like to tell you, you just can find normal breast component, including the granular component, stroma, fat, and what other normal breast component you can see in the breast. But the key feature is they are not organized well. So this is a gross image. We can see this well demarcated, kind of encapsulated. If you do not know this is a mass, you just thinking about this is just a normal fat. And then this is a well circumscribed mass and nodule, and then you can see different kind of component: normal, granular, normal duct, maybe a little bit dilated, and then we have fat, we have trauma, we even have some smooth muscle here, but the whole thing just like disorganized. They're just everywhere, and then they form a mass. So that is the hamartoma. It's another one. If you didn't see the margin, just see this area, you tell me kind of like normal breast. But when you see this is a mass, and then we have all the normal component but just disorganized, that is the hamartoma. Another one, we have all the normal component but just this fat just jumping everywhere. This TTL could not form a lobule, and then no duct connect or beside this lobule. So everything just disorganized, but benign hamartoma. Okay, let's see some cases. The first one is 39-year-old female left breast mass. So in the core biopsy, it seems like we can see some normal TDLU of the breast, and then in this mass, we just can see this spindle cell proliferation kind of hypercellular, but no any epithelial proliferation. So for this case, we will sign out just fibroepithelial lesion with phyllodes feature and see comment and tell them the differential. And then of course for this case, the surgeon take this mass out, it turned out to be fibroadenoma. Another case, 23-year-old female, breast mass, excisional. So from this block, we can see this biphasic tumor, proliferation of this epithelial component and also the stroma, a little bit subepithelial condensation, but we do not see really clear leaf-like structure. But more importantly, we can see this well-demarcated border, so we know this is benign. And then in other image, we can see clearly this leaf-like structure in low power and subepithelial condensation. So this one turned out to be benign phyllodes. The last one, 45-year-old female, right breast mass, and then we can see relatively well demarcated mass. However, even in this image, you can see the cellularity is much higher than the benign phyllodes. A little bit, maybe a little pushing or maybe infiltrated, just could not tell. But really clearly this should be fall into the phyllodes tumor category. Then another maybe pushing border or maybe infiltrated, just not sure, but the cellularity is too high. And then we can see this high power, we have vesicle growth almost forming this herringbone. And then this area, just right to show you some mitosis and then some atypical cell, a little bit polymorphism. We have a little bit cell with dysprominent nucleoli, and the cell is not perfectly spindle cell, kind of epithelioid looking. So this one turned out to be malignant phyllodes tumor. Thank you for your attention.